Diagnosis and management of occupational diseases. Work-related asthma. Asthma. Asthma is a chronic inflammatory disease characterized by episodic dyspnea, shortness of breath, bronchial obstruction, which can be significantly reduced by inhaled bronchodilator medication, nonspecific bronchial hyperactivity, increased diurnal variability in lung function. Work-related asthma. Work-related asthma encompasses two main types. 1. Occupational asthma, OA, caused by exposure to workplace allergens in individuals with no pre-existing asthma. 2. Work-aggravated asthma, WAA, exacerbation of pre-existing asthma due to workplace allergens. Occupational asthma, OA. OA is defined by airway inflammation, reversible variable airflow limitation, and airway hyperresponsiveness due to causes and conditions attributable to a particular occupational environment. Diagnostic criteria. History. Occupational exposure to substances known to induce OA. Symptoms sequence directly related to work schedule. Symptoms may begin minutes to hours after exposure. Symptom recurrence upon re-exposure to the same agent. Examinations. Potential absence of clinical signs. Rhonchi detected during an attack upon chest auscultation. Investigations. Skin prick test/serological testing for specific IgA antibodies. Serial peak expiratory flow/spirometry during work and non-work periods. Specific bronchial inhalation challenge test. Exposure criteria. Sensitization period ranges from a few weeks to years, can be as short as a few days. Maximum latent period between exposure and symptom manifestation is 48 hours. Common substances causing OA. High molecular mass substances, glycoproteins. Animal-derived allergens, arthropods, plant-derived allergens, enzymes. Low molecular mass substances, chemicals. Diisocyanates, acid anhydrides, amines, rosin, some wood dust components, metals, drugs, biocides, plastics. Types of induction. Sensitizer-induced. Presence of a latent period. Involves a sensitization process. Irritant-induced. Non-immunologic. Typically no sensitization period, but may mimic latency with cumulative exposure. Reactive airways dysfunction syndrome, RADS. Develops without a period of latency, often after high-concentration irritant exposure. Non-immunological with hyperreactivity, may progress to persistent asthma. ACCP medical case definition for OA and WAA. OA. Physician diagnosis of asthma and/or physiological evidence of hyperresponsiveness. Occupational exposure preceding symptom onset. Symptom association with work. Physiological evidence relating asthma to the workplace. WA. Meets criteria A and C of OA. Pre-existing asthma or recent asthma symptoms. Increase in symptoms or medication requirement, or work-related changes in PEFR or FEV1. Management of occupational asthma. Clinical management. Inhaled corticosteroids with rescue beta-2 agonists. Immunotherapy in selected circumstances where allergen avoidance is impossible and standardized extracts are available. Occupational management. Compensation. Occupational asthma is compensable under employment injury schemes. Diagnosis is crucial for compensation purposes. Work modification. Better control of exposures. Removal from exposure to causative agents for sensitizer-induced OA. Optimize asthma treatment and reduce workplace triggers for irritant-induced or work-aggravated asthma. Primary prevention. Control of exposures for workers at risk. Examples: substituting agents, isolating processes, improving ventilation, using respiratory protective devices, educating workers. Secondary prevention. Medical surveillance programs to detect early sensitization or sensitizer-induced OA. Tools include symptom questionnaires, spirometry, and serologic tests or skin prick tests. Investigative tools. Spirometry. Establish airway obstruction. Measure reversibility with bronchodilators, improvement greater than 12% in FEV1 or FVC and greater than 0.2 L absolute improvement. Serial peak flow monitoring. Establish occupational relatedness. Criteria include deterioration at work compared to rest and increased within-day variability during work. Skin prick test. Tests for immediate hypersensitivity, IgA antibodies. Indicated for suspected specific allergens. High sensitivity and specificity for identifying responses to protein allergens. Workplace investigation. Confirm presence of hazards. Assess exposure levels, control measures, and coworker health. Conclusion. The effective diagnosis and management of work-related asthma require a thorough clinical evaluation, appropriate diagnostic testing, and a comprehensive approach to occupational management. Primary and secondary preventive measures are crucial to minimize the risk and progression of occupational asthma.